Associate Professor Penelope Bryan is from Hospital in the Home at the Royal Children's Hospital here in Melbourne. So Penelope is a paediatric infectious diseases physician and a general paediatrician who's trained and worked both in the UK and here in Australia. Penelope is the medical lead of Hospital in the Home at the RCH. She's the group leader of the Murdoch Children's Clinical Paediatrics Group, through which she researches ways to get children home safely with the support of an investigation grant. Penelope is also the paediatric lead for the HITH Society of Australasia and was the 2019 recipient of the Dr. Nicholas Collins Award from the Society. So it's a great pleasure to have Penelope telling us about some interesting OPAT delivery models that can improve children's quality of life and their school attendance. So over to you, Penelope, thanks.
So thank you very much, James and Jason, for the invitation to speak at the CRA Reduce webinar series. I'd like also to acknowledge the traditional custodians of the lands on which we're all meeting, many different traditional custodians, and pay my respects to their elders past, present and emerging. I was given this title, Interesting OPAT Delivery Modes, which puts a little bit of pressure on me, so I decided to change it to Lessons in OPAT from Children. But I think there are a lot of lessons for everybody from children. I think we can all learn from each other, and I certainly think that what we've learned from children is something that we also took into our COVID response, and which also I've discussed with adult colleagues and perhaps even aged care settings. It's not that much different sometimes. So I wanted to start by just actually taking a step back and going, why am I even speaking at this webinar series? Because how does OPAT and HITH actually help the goals of CRE Reduce? So the goal is redefining antimicrobial use to reduce resistance. And I think the main way that OPAT and HITH really helps this is to reduce in-hospital days in an effort to reduce both the acquisition and also spread of hospital-acquired infection, which has a vastly higher rate of antimicrobial resistance in it than community infections. As a side product, it very helpfully improves the quality of life and family dynamics of patients. It allows earlier return to school and work, and is cost effective for healthcare systems. But there is another opportunity for us all, particularly in the OPAT space, to help this goal in reducing antibiotic exposure. And so there are opportunities to cease OPAT even before it starts, when the patient is referred. It's often a difficult time to cease it, because once the patient thinks they're going home on IV antibiotics, it's a little bit difficult to roll it back at that point. Colleagues of ours in Salt Lake City in Utah did a retrospective review and looked at all the opportunities to cease and said there were many, but when they did their prospective study, they found it a lot more difficult to actually make that happen. But I think there are opportunities to limit the duration of an OPAT stay. And for example, in our hospital in the home, anyone who's referred for longer than 2 weeks of IV antibiotics has to go through, well, basically me. And that's easy-ish for me because I'm an ID physician. But I think there are opportunities in other areas of hospital in the home as well. But there is the opportunity for daily medical oversight of patients who are often out of sight, out of mind for their referring teams. And for example, if you're using something like CRP, which we use to plot trends in improvement for bone and joint infections in children. If you are seeing that the patient hasn't had a CRP and you can do a CRP, and that means you can switch from IV to oral antibiotics earlier, then that's a good thing. And it also limits the number of antibiotics you can use. So we frequently have patients referred who've been treated in hospital for a brain abscess and who've come in and been treated with flucloxacillin, ceftriaxone and metronidazole, and then they magically get pulled down to just ceftriaxone and oral metronidazole when they come to hospital in the home. So I think there are some very specific antibiotic issues that we can help with. But what I'm mostly going to talk about today is what we've learned more broadly on HITH in reducing in-hospital days. So I like to always start with a summary of my talk so that people for whom they have to rush away in the middle of the talk actually know what the talk was about. And this is going to be why are children different from adults and what unique problems that presents for OPAT and HITH. what solutions have been found, and then what lessons can we apply for all home care. So I think there are many differences between adults and children, but the things I think as it's relevant to HITH is that the benefits of home are greater in children. The acuity of their illness is often higher. They're not just little adults, we say that a lot, but it is true, and they're inseparable from their family. So as far as the benefits of home being greater, whatever you think the benefits of home are in adults, it's a logarithm greater in children. Quality of life comparison between hospital and the home is dramatic. When children are in hospital, they miss their families, they miss their siblings, they miss their pets, they miss school, they miss playing outside, they miss their friends, and they miss home cooking. And those are all pictures of my children at various stages in their life. And my children are ridiculous, but the couple of times when they have been in hospital, these things have been true. Children don't understand the reasons they're in hospital, and often parents may need to leave them at points during their stay. And so our solution has been to proactively seek patients to treat with OPAT and HITH. Our action has been referred to by one of my infectious diseases colleagues as daily aggressive in-reach. We run our HITH as a virtual ward, so a little bit different from the models that have been described this evening, but we run it as an inpatient ward, but just as patients who are in their own beds rather than a hospital bed in the four walls of the children's hospital. But we attend bed meetings twice a day. We've built ward relationships with the care coordinators on all of the different wards. We do regular education with every new cycle of junior doctors, and we semi-regularly run campaigns with posters, as you can see on the side there, and screens in the hospital lifts. And we also try to run with a genuine, yes, we can do anything attitude. Yes, please refer us your patient. If you can't solve the problem, let us try. And I'm going to talk about that a little bit later. The other thing we've done is made a concerted effort to expand our HITH. So HITH at RCH started in 2003 with 5 beds. And when I arrived in 2011, we had 16 beds. We fairly rapidly expanded to 32 beds in 2012, and then 50 beds 3 years ago, and we're just about to expand to 60 beds. And the way to do this is really, we've done it in a number of different ways, is really seeking patients from new areas in the hospital, such as day oncology, outpatients, the neonatal intensive care unit, and even PICU. During COVID, we had a COVID positive patient who was under a PICU bed card on HITH, which was a first for us. The largest area has been from new teams and thinking about new conditions, and specifically and particularly focusing on those in the too hard basket. And that includes neonates, who people often worried are too fragile, particularly premature infants, kids with developmental difficulties, such as autism. We had a patient once who was initially referred for treatment of their cellulitis to HITH, and then somebody said, oh, they can't possibly come to HITH, they have to stay on the ward, which seemed the opposite of what you should do with a child with autism. And the reason was they were worried that they might pull their cannula out if they weren't on the ward. Well, on the ward, they pulled the cannula out and they sent them home anyway. So we've made a concerted effort to try and seek out those kids, and also vulnerable families, including Indigenous families who may have reasons why they don't necessarily want visitors into their home from official services. So taking on new patients, patient groups needs innovation. It starts with an idea, and sometimes the idea is just as simple as, why don't we do that? Why don't we take these patients? But if you're having difficulties of thinking of ideas, conditions that are common or long stay are low-hanging fruit. It requires planning, who to involve, and what are the specific barriers before you even start. And then collaboration is probably the most important part of it, because unless you can sell to an inpatient team that you will be benefiting their service and their patients, and they won't be interested, and it has to be more than just cost effectiveness. It sometimes, but not always, needs resourcing. So you may need new equipment or staff with different skills. And then I think we do it too infrequently to audit our new patient groups and make sure that what we're doing is working. So I just got some examples of things that we've done along the bottom here. So this was a a patient group of looking at children post-complicated appendicitis repair, and we could see that these patients were staying around in hospital. Appendicitis and appendicectomy is a very common condition and surgical procedure in children, and they were in hospital really just for IV antibiotics. And when we spoke to the surgeons, they said, what we really worry about is that they're going to get a complication. I said, well, they might get a complication in the hospital, so what are you really worried about? And they said, what we're really worried about is that nobody's going to notice. And so to engage them, what we needed to do is say, right, we'll have the medical junior hospital in the home fellow lay a hand, go out and visit the patient and lay a hand on their tummy. They didn't want somebody just giving IV antibiotics. They wanted an actual hand on the abdomen. We've done quite a lot of work in oncology, so from an antibiotic point of view, low risk febrile neutropenia, and again this required collaboration, but resourcing was relatively familiar. As somebody said in the previous talk, actually giving IV antibiotics is the easiest thing that we do. Some of the more complex things that we've done in oncology, and particularly during COVID, is to take some of the patients who would have normally gone to day oncology when we were having restrictions on who could enter the hospital. And so we've started giving intravenous vincristine at home. And we also do a lot of hydration, pre and post hydration around chemotherapy for some solid tumours such as osteosarcoma and medulloblastoma. We looked at a large, what was a large population of young infants that were coming in, and the largest complicated patients were infants with failure to thrive because of feeding issues, and a lot of these infants had issues that were beyond a simple gastroenterological problem. There were often psychological, psychosocial bonding problems. There were potentially social issues with the family. Sometimes the babies were premature and just hadn't really worked out how to feed. And for this, we actually did require quite a lot more resourcing, and we developed a program which we call the Joey program. Our hospital in the home is called Wallaby Ward. All the wards in the children's hospital have an animal name. So hospital in the home is Wallaby Ward, so that children can hop out of the hospital. And so this was the Joey program, which was really for supporting infants who were having difficulty feeding and failing to thrive. And so we employed maternal and child health nurse, dietitian, and a speech pathologist, all to support these infants. We also identified the other large group of infants who come into hospital and for much shorter stays, though, are infants with bronchiolitis. And initially, because we couldn't give oxygen at home, we were just taking patients that needed hydration assessments and respiratory assessments and feeding support. Although subsequently we've started taking children with oxygen, which I'll talk about in a moment. But all the time we're still looking for new patient groups, and the current patient group that we're looking at trying to support at home and trying to get them out of hospital is adolescents with eating disorders. And there's a dynamic in adolescents with eating disorders where the adolescent team want to encourage them to be independent, but they're often quite fragile, and hospital in the home offers transition between hospital and independence in the home. So the lessons really are that more patients, more patients could be treated at home via HITH, and that research and innovation are essential to challenging dogma. So secondly, the acuity of their illness is high. As anyone who, well, I was going to say even knows a child, but certainly anyone who has a child knows that children get sick quickly and they get well quickly. Them getting well quickly is absolutely why they should come to hospital in the home. But unfortunately, because they get sick quickly, everybody worries about them. And when they are sick, it is difficult to persuade clinicians of care at home. So we were getting very few patients directly from the emergency department. And for physicians who were used to seeing patients in front of them, familiar models appeared safer. And when we did try and say we wanted to get patients home, they would often say, you know, show me the evidence that it's as good. So the first solution was to increase medical review while on HITH. If the problem is the physicians, then we'll try and replicate physicianness in the home. We employed a paediatric fellow who's dedicated to visiting HITH patients, and we also introduced telehealth so that patients could be reviewed in the home. And telehealth does seem like old hat now, but we did this in 2012, so it was a long time ago, and we really felt that we were pioneering it, and it was well liked by both patients and medical staff as a way of just being a little bit more eyes on. There are actually many other technological solutions to improve eyes and ears in the home. So our staff use a special kind of smartphone called a SpectraLink, which is connected directly to our electronic medical record, but also has all of the nursing needs on the phone, but also has some other things like being able to monitor where they are. And as you can see, that little red alert button on the top for just for additional safety. During COVID, we improved our telehealth with particularly when we're trying to do some less hands-on visiting, and we would deliver thermometers and pulse oximeters to patients' home and do a sort of hands-free visit, and they would keep the thermometer and pulse oximeter for their stay, and then we would do telehealth visits. Other places, not us yet, although we're looking at this at the moment, do continuous monitoring. I know this is quite well known in adult HITHs, measuring blood pressures and pulse oximeters, and having that go directly back to the electronic medical record. The problem with that for us is that we don't have somebody continuously watching the results of monitoring, and so until we've got something more robust overnight, it's not a useful thing to do. And then I was speaking to colleagues of mine in Israel a couple of nights ago, and they said, "Oh, do you use remote stethoscopes?" And I was like, "Remote what?" I do know these things exist, but I haven't used one. But this is, they said they use these all the time, and it adds to their ability to have oversight and examine children in the home. And that second picture there is a wireless remote telescope, which seems very cutting edge to me. And so then the other thing is, the solution is to generate the evidence that the physicians are asking for to support home management. And I am completely passionate about research in hospital and the home, and I think we should all be doing more of it. We have published quite a lot of the work that we've done. Some of it's audits, some of it's reviews, some of it's news scores, some of it is looking at investigations and better ways of caring for all sorts of different kids in the home. But I want to just take one example, which is a randomized control trial that we did, which was the first randomized control trial for children looking at effectiveness of hospital in the home, OPAT, versus hospital care. And so we decided to make it the most acute setting and do an RCT in the emergency department. And we have a very research active emergency department at the Royal Children's Hospital, so we're lucky and we collaborate well with them. And it started with the idea that adults with moderate severe cellulitis and ED are treated at home, and why on earth weren't we doing this in children? And there were multiple barriers. It started off with the fact that the chicken and egg of our hospital and the home just not being nimble enough. We just weren't able to take patients the same day. And you have to have a HITH that can take patients the same day if you're taking patients, or at least the following day if you're taking patients from the emergency department. But also the chicken and egg of it is that if you don't have the patients to do it, there's no point, the hospital executive are not going to want to expand. So you have to sort of sell that you are going to get the patients. In children, there are non-ideal antibiotic choices for cellulitis in the home. So in hospital, we use 4 times a day flucloxacillin. In the adult world, you use cefazolin with probenecid, but kids vomit probenecid, so it's not really a useful option, and really leaving us with just ceftriaxone as a once daily option. And also the concern that children more acutely unwell. When we first floated this idea with the general paediatricians, they said, but what about all the children with necrotizing fasciitis, which children with cellulitis and necrotizing fasciitis don't present in the same way, but there's always that sort of niggle in the back of your head. What is the worst thing that could happen? And I don't want to be the person who misses it. Fortunately, the emergency department deal with that kind of anxiety every day, and so they were very keen to support this. So we resourced a HITH registrar by writing a business case to include emergency transfers in the model, and we started using once daily ceftriaxone for OPAT for selected patients. And then once we had done that and we showed the general paediatricians that it worked, they said, yes, but how do you know the ones in the hospital aren't completely different? So then we did a comparative cohort study of OPAT for more patients, and we included blood cultures because they said, how do you know they haven't really got sepsis? And we showed that no patients with cellulitis over a 1 year period ever had a positive blood culture, except apart from some false positives. And presented this to them, and they said, yes, but it isn't a randomized control trial. So we did a randomized control trial, and before I say anything about it, I will say that halfway through the randomized control trial, the general paediatricians are like, why are we doing this randomized control trial? Everyone does great at home. And it's like, because you made us do it, so you have to still keep randomizing the patients. And we did, we randomized patients in the choice trial to hospital or home, ceftriaxone at home versus flucloxacillin in the hospital. And every single measure that we looked at beyond our expectations was better at home. So the primary outcome was treatment success, and home was better. But we looked at all of the other outcomes. So adverse events, home was better. Patient satisfaction, home was better. Hospital costs, home was better. Family costs, a little bit surprisingly, home was better, and it's the first time that that had ever been shown in any HITH. And parent satisfaction, which is only modelable with a cocktail, home was better. But specifically for this talk about antibiotic resistance, you'll remember that we said it was ceftriaxone at home and flucloxacillin in hospital. And I've heard lots of talks at different OPAT and hospital in the home conferences talking about, oh, we need ceftriaxone because it's once daily, but it is a bit evil because it's a third generation cephalosporin. And I looked in the literature and just could not find any data on anyone looking at its use in hospital and the home. So it has been shown to be evil in adults, in intensive care settings, oncology settings, and much less in children, but in children too, in NICU settings and PICU settings. But we really wanted to know, if it's the only thing that we can use, do all of these other things outweigh any increase in resistance? And we thought they probably did, but we obviously had to measure resistance. But what we found was absolutely no difference in resistance. We looked at MRSA, we looked at ESBLs, we looked at C. difficile, and there was no difference between the two groups. Almost certainly because these are healthy children with no comorbidities, with very short durations of ceftriaxone, but still it was a real finding. And this was published in the Lancet Infectious Diseases, and the only reason I put this slide up is because it made the front cover, and I made a little animation of it because I'm a paediatrician and I can't help myself. If anyone would like me to animate anything they have on PowerPoint, please let me know, because it's my joie de vivre. So then we have to ensure that the evidence has impact. So the first thing that we did was got these results into the Royal Children's Hospital Clinical Practice Guidelines, which are used in Melbourne. And then these eventually made their way into the Paediatric Clinical Practice Guidelines, which were initially statewide guidelines in Victoria, but are now being used all the way up the eastern seaboard. And then hopefully at some point the rest of Australia, and then world domination. And we've built on this ED to HITH for total hospital avoidance, sort of in the lead up to this, but certainly since this. And in the last number of years, we've had 787 patients come directly from the emergency department. And we have a 7% representation rate and a 4% readmission rate, which is pretty amazing when you consider that these children, unlike a lot of children who come from the wards who have been stable for a period and are on the potentially downward trajectory of their illness, these kids are still on the upward trajectory of their illness. At least 2/3 of what we do is OPAT, primarily almost half of it for skin and soft tissue infection, and then which is the blue, and then the green is other infections. Again, most commonly UTI pyelonephritis, but we do a whole lot of look after a whole lot of other conditions which don't require OPAT, which you can see on the right there. So the lessons really is that to address barriers may need resources, innovation, blood, sweat and tears. But that HITH can potentially look after patients of a higher acuity, and it just requires planning. But I'd also say don't stop once you've got your research answer, ask the next question. So after the choice trial, rather than just saying, okay, great, ceftriaxone's good, it's still ceftriaxone. We still don't really want to use it if we don't have to. So we've developed a tool to try and reduce how many patients we even treat with IV antibiotics with moderate to severe cellulitis. We're trying to work out if there are other antibiotics that we can manipulate to use less frequently, but that are narrower spectrum. Similarly with UTI, people are quite comfortable now with treating UTI in hospital in the home. But again, we've developed a tool to try and reduce the number of patients we get, and we're just about to start a multi-centre randomised control trial supported by MRFF to see whether we can give once daily IV antibiotics in the ED for pyelonephritis in children. Because if we can do that, they don't even need to come to HITH. They could just have their 1 dose of IV and then go home on orals. So thirdly, they're not just little adults. And while that creates some challenges, it also creates some unique opportunities. So we look after children on our hospital in the home from 1 week old babies to 18-year-old gigantic adolescents, and every size and shape of children in between. And what this really, the problem this really raises is that different ages really do have different management needs. So they have different needs of IV access, different gauges, and neonatal lines, for example, can't be HEP locked. And young children are very good at pulling out their lines, but it's also difficult to put them in. So they need a general anaesthetic, they need strong fixing. The infusers have different sizes and flow rates, so we need to be cognizant of that. Drugs have different concentrations and different doses at different ages, although we're quite used to that as paediatricians. That has to translate into, well, then how does that work with the different concentrations? And for example, other things like oxygen saturation probes, some of them are just unreliable in infants, and so you need to be careful what type you use. And so I'm just going to give you 4 quick examples of problem solving that we've done, because I think that the challenges that we find in children make us need to do problem solving, but I think that's part of the joy of HITH. I think it's something that I actually really enjoy doing. So the first one was a adolescent girl with cystic fibrosis who needed a certain concentration of imipenem, but we just couldn't get enough imipenem into her with the size of Baxter, and so we innovated and we worked out how to use a double Baxter so to get the right amount of imipenem into her through a Y connector, which she carries around in a bag. Then we had a situation where we were trying to give vaccines in the home for the first time, and in Australia in the summer, car boots get very hot, and we didn't have the money to buy fridges for all of our cars, and so we were worried that we were going to break the cold chain, and that obviously isn't a good thing. And so with that, we came up with a solution of using freezer boxes, which had freezer packs in them, but also had this something called a log tag, which if it goes above a certain temperature, a little red LED light goes on, and so you know that if the red LED light isn't on, you haven't broken the cold chain. Thirdly, for our children with bronchiolitis, I mentioned earlier, I talked about the fact that we had we weren't able to use oxygen, and that's because it takes several days for us to be able to get tanks of oxygen and get approval for that. And by the time most children actually would get the tank of oxygen, their actual need for oxygen would have disappeared. And so then we spoke to some of our colleagues who work a lot in the third world, and they told us about oxygen concentrators, which we sort of peripherally knew about, but had never really tried to use in hospital in the home. And that obviously is immediately available, and they work by concentrating oxygen by extracting the other gases out of the air. And so as soon as a child is diagnosed in the emergency department, they do have a 4-hour period of observation, but then they can go straight home with an oxygen concentrator that just sits in our department. And then finally, back to antibiotics. As most of you will be aware, there are some antibiotics that you can give once daily. There are some antibiotics that you can put into a Baxter over a 24-hour period, and there are some that you just can't. And for the ones that are definitely BD, when you have children that live far away, we service a 60-kilometre radius from the Royal Children's Hospital with our own nursing staff, and we outsource to the rest of Victoria through other community services. Some community services services just don't have the capacity to go and visit a child twice a day. And so we had a child who needed ciprofloxacin, and we just could not work out how we were going to get them home. So again, we innovated by giving them 1 dose IV and 1 dose oral, and we worked out how the pharmacokinetics would work of that and the timing of the oral dose. And that was a solution that worked very well, because it was felt that they really did need some IV, but actually it was realized that probably we were treating ourselves by saying they needed both doses IV. And so we also use the opportunity of seeing them at home to add some paediatric specific values. So the way that we do this is by having a team of very diverse resources. And so we have obviously nurses and doctors, we have physiotherapists, we have a maternal child health nurse, we have a pharmacist, we have a dietitian, that's supposed to be that guy in the sweet corn. We've recently employed a social worker. We had a mental health nurse for a while, but unfortunately we couldn't afford to keep her. But I think resourcing your HITH as you would resource a ward, if you have a HITH that's big enough, and that's one of the kind of powers of scale of HITH, really allows you to do some great things. We're just about to start a project with Adolescence doing head screening, which is the health, education, alcohol, drugs, I can't remember what the other D is, and suicidality. And it's something that we do very badly on HITH in general. But it's much, the fact that an adolescent is at home is a much better environment for them to actually sit and do it on a tablet, or send a link to them so that they can do it, rather than having to sit in a clinic or sit in the hospital. We also use the fact that in COVID last year that we were seeing children at home, that many fewer children were able to attend their GP and have immunisations, to contribute to the flu vaccine campaign and top-up vaccines. And that was enormously popular with families, and we've continued that, even though families can now see their GPs doing that opportunistically. So I think problem solving is an absolutely core skill for HITH, and some conditions and interventions do need different staff, and this needs executive support and really executive championing and funding. And then finally, children are inseparable from their family. So this is both good and bad. It's good because they are very well at home in their family environment, and much better than being out of their family environment in hospital. But we do have some families who have much less capacity than others, and so we have chaotic families with parents who can't remember HITH visits or coordinate the times of HITH visits. We've had situations where parents just aren't present when we attend the home, and children are being looked after by or looking after other children in the family, and parents being incapacitated by alcohol. And then there are safety issues for staff, which is not the sole domain of paediatrics, certainly. But we have children where there's a history of family violence, and parents who've just been released from prison or on the sex offenders register, and children where there have been multiple code greys on the ward, called usually for parents, sometimes for adolescents who are struggling. And so the solutions are really to try and focus on the fact of always remembering that the child is the patient. And so we've developed flexibility in how and where to see patients. So we see patients at school, not frequently, but that's a good solution for families where visiting in the home is just difficult for the family. And sometimes in organised accommodation, we have Ronald McDonald House where families stay, and we frequently visit in Ronald McDonald House, but we've even visited patients in the hospital as the hospital and the home team. So we have something where neonates go after they're being transitioned from the NICU to home. They'll often spend a few nights in care by parent, where their parents are supposed to be learning complete independence. But sometimes they're still on IV antibiotics if they've got meningitis, for example, and needing 3 weeks of IV antibiotics. And so we do hospital in the home in the hospital. We also have flexibility in when to see patients, and we try and time this around school and around parent work. So it's very popular for us to go before 8 o'clock and after 4 p.m. But that's something that we really make a conscious effort to do. We've done lots of problem solving around safety for staff, which I'm not going to spend too much time talking about now. It's a very important piece of our work. And we also now have a social worker embedded in our HITH team who I just cannot speak highly enough of. She's amazing. So the lessons for this are really that solutions can be found to difficult situations through staying focused on the patient. And also, as you all know, adults also do better in the context of their family surroundings for the most part. So take-home lessons for me are that innovation, generating evidence, a can-do attitude to problem solving and flexibility are our core business in providing safe, effective care at home. But I do think we could all be treating more patients at home. And I did a talk recently where I said this, that adults can learn from paediatrics, but also we learn from adults. But I do challenge people when I give talks about hospital in the home to come up with one new patient group that you think you could treat at home. And it doesn't matter about the barriers, doesn't matter about the resources, just think of what that group could be and then try and problem solve how you could make it happen. I put this up as a sort of advert, although most people here are probably not going to be paediatricians. It's not really an advert for our services, but we put a lot of our resources on the Wallaby website at RCH, and we did a lot of work around COVID, which was supported by the Australasian HITH Society, but we also have lots of other resources around nursing care. So thank you very much to all of my colleagues, and I particularly note Dr. Leila Ibrahim, who led the choice study, which was my PhD student, but also funding support that we receive generously for our programs. I've put a little QR code there, just if anyone's interested to look at some of the research we've done and see whether it's helpful to them. It's just a QR code to a Dropbox, and then I will welcome any questions with the rest of the panelists.
Thanks, Penelope. Fantastic overview, and I think really useful to be able to draw the parallels between adult and children, but also know where the differences are. So that's fantastic. While I've got Penelope there, so Sean Unwin from Brisbane was asking, with the, you mentioned the dosing of the ciprofloxacin and the oral dose. Do you train parents or carers to administer self-OPAT type model?
It's a really good question, and I don't think we do it enough. But I also, when we have tried to do it, particularly, there are two groups of families. There are families who have only a very short course of IV antibiotics, and where the training would take as long as it takes to actually give them. And then there are families where they might be giving very frequent antibiotics, particularly, for example, kids with cystic fibrosis. What we have found, though, is that when we have started teaching parents, initially they quite like it, but after a while they're just like, it's just another burden, it's just another thing for them to do. And sometimes they actually found their children coming into hospital a slight respite for a couple of weeks. And so we don't really want to pass too much of the burden onto parents when they're already looking for respite. I think it's probably done better in adult care, but we've sort of pulled back a little bit on our attempts to do that.
And the other one was around your readmission rates. You mentioned, so you did the project straight from ED, yep, and you had a pretty good readmission rate. It was excellent. Yeah. Do you have a comparator to if the ED sends someone home without a hospital in the home care, what their standard representation rate is?
Yeah, that's a really good question. I'm not sure that it would be a particularly useful comparison, because if they're sending kids home without hospital in the home, or without being admitted, they're presumably less sick, and therefore they would have a lower readmission rate. I think it's always good to compare everything. To the thing I was otherwise going to say is that we have a sort of 8 to 9% readmission rate generally in our OPAT service, but even that, I think it's not always completely helpful to judge, because I think services are different. Some services take on incredibly complex kids with or adults with multiple comorbidities, and therefore are always going to have higher readmission rates than a service that takes on a very simple cohort of patients. And neither is better or worse, but the readmission rates are not always comparable. And the other thing I would say about readmission rates is that even if you can get a kid home for a few days, even if they have to be readmitted, who cares? I mean, it's the vast majority of patients, and even the ones who are readmitted in the study, who said, we asked them afterwards, would you rather have gone home or would you rather have been in the hospital? And everybody went home. Everybody who was randomized to the home arm, even the ones who were readmitted, said, next time I'd want to go home. And 2/3 of the ones who came into hospital, randomized to the hospital arm, said, next time I want to go home. So
I think that's a great point, and I think, you know, getting them in and out safely is important. I think our panel from RBWH made a similar point in their cohort, in their aged care cohort, clarifying the, you know, goals of care, return to hospital, treatment plan. There are a couple of other questions there I just want to get to. Sam, you'd indicated there you're going to answer one for us around continuous furosemide infusions, IV or subcut. How are you managing are you doing bolus furosemide, are you doing infusion, are you doing a mixture? Just talk us through that.
Yeah, most of it's BD visits to do bolus, 2 doses a day. The IV infusion can happen, but it is a little bit more logistics from the pump point of view. The patient needs to be able to be, well versed in seeking help if the pump is not working. So on the whole, we just stick with the BD dosing.
So do you teach the staff at the nursing home anything to do with the PIC line, or you retain responsibility for that alone? How do you manage that?
Yeah, we retain responsibility. We obviously make them aware of the reasons to call for support, but it's a lot of the time it's out of their scope of practice, so we don't expect anything of them around that apart from reporting a concern.
No worries, thanks. And maybe one for Michael, just you mentioned blood transfusions, and there's been a couple of questions on the time it typically takes to deliver a unit of blood, 3 to 4 hours. Do you use a single nurse? Do you do dual nursing visits? Do you have issues with the fridges on sites at the nursing home? Can you just talk us through some logistics on that one?
Yeah, I guess logistics isn't really my thing. The reason being is that we have a centralised Metro North HITH facility that services for all 4 hospitals in the Metro North side of Brisbane. So we tend to order them and they deliver. So Sam has deeper insights to that side of things because it's about a 40-kilometre away service from our hospital.
You want to add to that, Sam?
Yeah, thanks, Michael. Just briefly, so we have a low threshold to run a unit of blood over 2 hours. Unless they're obviously compromised from a heart failure point of view, fluid overload point of view. The nurse stays with the client the whole time, and the nurse arrives with the blood product. And generally speaking, if someone requires 2 units of blood, we do it over 2 consecutive days, purely because of that, the logistics of staffing resourcing.
And then there was also a question about the delirium pathway, which I gather is actually out of one of the other Metro North sites more so than RBWH.
Yeah, well, HITH as a whole utilises the delirium pathway for other non-aged care facility clientele, and that's where it's a OT-led pathway more often. They do a 4AT score each day, so you might err on the side of the client that lives in an aged care facility. Is with their constant staff, they've got familiarity of staff around them, so they might only be on the pathway for a couple of days. It's getting them out of the acute sector and making sure that they're stabilised and the delirium is actually continuing to lift as opposed to worsening.
We can happily share that if anyone, I think someone's asked to share it, so we'd happily share that if we can be connected offline.
Right, thank you. I think there'd be a great deal of interest in that. All right, we might leave it there with 1 minute left to the scheduled timing. I'm going to hand back to Jason, but I would like to very much thank all of our speakers. Unfortunately, Matt did have to leave a little early, the perils of the multi-time zone issues, but look, thanks very much to all our speakers, some absolutely fantastic presentations, and I'm sure both our live audience and those watching it back later will have found it a very entertaining session. So I'll hand it back to you, Jason, for the final farewell.
Thanks very much, James, and well done to all the speakers. Gee, they were fantastic talks. Some approaches to use of OPAT and hospital in the home and broader engagement that I had thought of, but didn't really appreciate previously in myself, and understanding the organisational aspects as well as the practicalities of making it happen. It was fantastic, and I congratulate all of you for your presentations, but also that the work you do to be successful in those roles. So well done. Penelope, specific comment to you to be going and looking at the mission for CRE Reduce and how that relates to your talk. That was fantastic, and I will be knocking on your door at some stage, I'm sure, to get some help with having some cleverer slides like you were able to manage. I really found that to be a wonderful evening, really, really interesting presentations. For those of you that joined as attendees, thanks again. These presentations are recorded and they are available on our YouTube channel and through the CRE Reduce website. And so please feel free to revisit these presentations and make sure that you are able to really drink in all of the knowledge that was shared tonight. I'd like to once again thank our sponsors, Pfizer, Gilead and Baxter Healthcare, as well as the University Hospital Neem, who helps us with our education program, and look forward to our third webinar, which will be in August, I believe, and I look forward to sharing more information with you about that in due course. So thanks again to everyone for your participation, and look forward to next time.